Welcome to Pediatric and Adolescent Depression in Primary Care. I'm Karen Koch, and I'm the Director of Mental Health Education at Eastern AHEC. This webinar series is part of our Child Mental Health and Primary Care project funded through the NC AHEC office. This funding allows the series to be offered free to participants from across the state. This project is also funding our monthly case consultation series with Dr. John Diamond from ECU Department of Psychiatry and Behavioral Medicine and Melissa Harrell, a licensed clinical mental health counselor. If you're interested in participating in the case consultation series, please go to our website, www.easternahec.net, to get more information and to register. Again, we thank you for joining us, and I'd like to go ahead and introduce your speaker tonight, Dr. Paul Trombley, a child psychiatrist, pediatrician at Prospect Behavioral Pediatrics and Psychiatry in Arden, North Carolina. He's a native of Detroit, Michigan, and attended Christian Brothers University in Memphis and graduated with a bachelor's degree in biology and a minor in chemistry and history. He attended medical school at the University of Tennessee Center for Health Sciences in Memphis. He completed his pediatric residency training at the University of South Alabama in Mobile. While there, he was recognized with the 2002 Best Resident Grand Round Award for original research. He is board certified by the American Board of Pediatrics and the American Board of Psychiatry and Neurology for both psychiatry and in child and adolescent psychiatry. He is one of the few nationally recognized triple board certified child and adolescent psychiatrists, with the only one in Western North Carolina. He holds an adjunct professorship at East Carolina University. He is an honored fellow of the American Academy of Pediatrics and a member of the American Academy of Child and Adolescent Psychiatry. Thank you so much, Dr. Trombley, for your presentation this evening. We'll turn it over to you.
Karen, thank you for that very wonderful introduction. Again, I'm Dr. Paul Trombley, a child and adolescent psychiatry here on the western side of the state. And I guess I'm going to be kicking off this entire series, which is quite an honor. Hopefully I will set the bar low enough so that people following me will do even better than I. But hopefully I will also be educating some people on some issues with pediatric and adolescent depression and how it really interfaces on primary care. This is kind of a busy slide. There are going to be a lot of things that we're going to be touching on this evening. I really wanted to kind of gear this about things, not just about depression per se, but other things to consider in primary care medicine that definitely impact children and adolescents, as well as existing population disparities and the role of sleep and other things that perhaps people haven't really thought about that much in how they impact depression. First, I kind of wanted to go over a little bit about mood itself. Mood has been defined as a critical element of health and well-being, a component of everyday life, and I think all of us could probably very much agree that we all have our moods day in and day out. Moods do assist with perceiving the environment, evaluating the environment, appraising the environment, understanding and navigating the world. And certainly changes in mood or fluctuations in mood are normal, and they can also be influenced by the culture in which we live. Variabilities in mood do have some clinical significance, but it's really more about duration and extent of mood shifts, where you can start really looking at things like, in this case, unipolar depression, but certainly also in the case of bipolarity or other mood shifting, that is really about duration and the intensity or extent of mood shifts that need to be paid attention to. Sadek and Sadek, one of the so-called Bibles of psychiatry, define mood as a pervasive and sustained emotional or feeling tone that influences a person's behavior, colors his or her perception of the world. Again, kind of a basic understanding of what mood really is. We know that mood disorders include the unipolar depressive disorders, major depressive disorder, unipolar depressive disorders, unspecified depressive disorders, bipolar disorders, which are typified by manic or in some cases hypomanic symptomatology or episodes, as well as depressive episodes. Hypomania, cyclothymia, which is really kind of defined as having periods of hypomania without any significant dysthymia or low periods, and dysthymia, a less severe form of major depression. Now, of course, in the context of this presentation, we're mainly going to be only talking about depressive disorders. I'll say bipolarity for somebody else. The DSM-5, the criteria for it is, of course, 5 or more symptoms over a 2-week period that must include the depressed mood or loss of interest or pleasure. Frequently, we see the depressed mood most of the day, nearly every day, which can be observed in others, or observed by others as well. Key in importance is that children frequently present with irritable mood state and not exactly more of a depressed mood state as one would consider or see more frequently in adults. There is a marked diminished interest and pleasure. Weight loss can happen, as well as hyperphagia, which is also fairly common. Insomnia or hypersomnia in children do tend to manifest more in hypersomnia rather than insomnia or dysomnias. Psychomotor agitation or psychomotor retardation, fatigue or loss of energy, feelings of worthlessness or feelings of inappropriate guilt, problems with thinking and focusing, and also decision-making, really an indecisiveness that can be seen. And certainly the suicidality, which is always the most concerning and dangerous part of any mental health illness, certainly depression notwithstanding. The B criteria is also fairly important because it really does need to clinically cause enough significant distress or impairment in some realm of functioning, be it social, academic, perhaps occupational, or just really not functioning. If you don't have a level of impairment, some experts would certainly opine that you don't really meet a criteria for a major depressive disorder, and whether or not you could still meet criteria for an unspecified depressive disorder, certainly. But a level of significant distress or demonstrable impairment should be present as well to make that diagnosis. Obviously, it's important to make sure that this is not because of a medical condition or the effect of substances. Obviously, it does not need to be attributed to like a schizophreniform disorder, schizophrenia, schizoaffective disorder, or any primary psychotic disorders where you may see negative symptomatology. And for major depressive disorder, again, to keep in mind bipolarity, there should not be any demonstrable or described manic or hypomanic episode. DSM-5 also has the modifiers of mild, moderate, severe, severe with psychotic features, partial remission, full remission, or unspecified. It's not uncommon that for a lot of us, we're seeing an unspecified depressive disorder, although kids can also manifest in a major depressive disorder or major depressive episode as well. A lot of primary care providers have probably seen this somewhere along the lines, these so-called SIGI caps, the pathognomonic to kind of remember these primary symptoms that you're screening for, S being sleep, I being interest, G being guilt, E energy, C concentration, A appetite, P the psychomotor agitation or retardation, and always the most important, that second S for suicidality. The mild to moderate major depressive disorder are characterized by the not having suicidal or homicidal ideations or behavior, or perhaps a passive suicidal ideation where there's no real intent, there's no active suicidality. It's something that can still be managed in an outpatient setting. Obviously, there should not be psychotic features, and even by definition, psychosis and depression is typically found only in severe depressive illness where you start seeing some psychotic features. There should be little to no aggressiveness, and there should be a level of intact judgment so that, again, no one is at imminent risk of being harmed. The PHQ-9 or Patient Health Questionnaire 9, you're basically looking to score less than 20 points. And this screening measure we'll actually be talking about much later in this presentation. With a major depressive disorder that's mild to moderate, it certainly is very amenable to treatment in an outpatient setting, or if you have one, a PHP or IOP. But these are the kids that can really be managed as an outpatient. Severe unipolar major depressive obviously are quite significant, with symptoms of 7 to 9 of these depressive symptoms occurring nearly every day. High PHQ-9 greater than or equal to 20, the suicidal ideation, the obvious impairment of functioning, and certainly, again, with severe major depressive disorder, the presence of psychotic features. These kids should definitely be referred to psychiatry, and if they're acutely dangerous, I wouldn't even waste time. I would not pass go. I would not collect $200. I would send them directly to your nearest ER to get them hospitalized. In terms of epidemiology, this has actually been changing, especially within the COVID pandemic. In 2013, the risk of depression, Wesselhoft and his group found that it certainly increases in childhood. The CDC survey, as you can see, a very large N of 78,000 US parents in 2007, demonstrated that even down to 3 to 5 years of age, there is actually a point prevalency of 0.5%. So even very small kids, toddlers, and early school latency age can certainly manifest depressive symptoms, up to 1.4% in the school latency ages of 6 to 11, certainly much higher. In fact, really over doubled by 12 to 17 years of age, with a prevalency rate of 3.5. Now, this is a very important slide because over time, we found that these are getting to be even higher and higher over the years in subsequent samples. We know that 1 year and lifetime prevalency rates of depression are really increasing. Burmeyer and his group demonstrated that there is an estimated prevalence of 2% for children, 4 to 8% in adolescents. Even by a later CDC survey in 2010 and 2011, they demonstrated that the prevalence rate is again getting even higher from the entire age range of 2 to 17 years, up to 8%. Avenole also found that the prevalence in adolescents is up to 11%. So again, you can see that these numbers are just rising and rising and rising through sample periods. One group has found that the 12-month prevalency rate of major depressive episodes have increased just in a few years from 8.7 to 11.3% from just 2005 to 2014, in that these rates are just, again, rising and rising and rising. All of these are also important for some of our primary care colleagues because depressed adolescents definitely also are strongly predicted to then go on to have subsequent major depressive episodes as an adult. So there is certainly evidence to suggest that if you have a depressive illness as a child, you are likely to have more depressive episodes as an adult. There's a strong predictive factor to that. So in some ways, we're not just really talking about child and adolescent depression. Really, this extends throughout the lifespan. And when a child or adolescent has been depressed, moving forward, you definitely need to continue to monitor for further depressive episodes well into adulthood. Interestingly, in adolescence, there is a double the rate of female to male ratio of major depressive disorder. However, interestingly, in one meta-analysis in 2014, it actually was found that in younger children, the prevalence is actually higher in boys, 60%, as a matter of fact, with an odds ratio of 1.6. So although we frequently may think about that depressed female, really you don't want to miss the fact that there are a great number of depressed males as well. They just may be manifesting different symptoms and may talk about it in a different way. We also do see that in different ethnicities and races, that even the language that is being used is really different. And that really needs to be taken into account so that you can adequately screen for depression and treat the person, no matter how they're trying to describe this. Now, of course, what lecture in pandemic times would be complete without something about COVID? Just recently, as a matter of fact, in JAMA Pediatrics, one group has already started looking at the effect of COVID on both anxiety and depression. And what we've already found is that there is a quite significant, almost doubling of the rates of depression and anxiety in the years previous to pandemic into where we're at now. Racine and their group found that the rates had gone from 12.9 and 11.6 for depression and anxiety, basically doubling to 25.2 and 20.5% for depression and anxiety, respectively. So we're definitely seeing, and perhaps a lot of you have even seen in the regular press, that really the mental health crisis has been declared an emergency with the COVID-19 and all of the rates just shooting up and people really needing help. The same group suggested, and I think this makes a lot of intuitive sense, that the loss of peer interactions, the social isolations, the reduced contact, even some of these buffering supports probably have really precipitated a lot of these increases in the rates of depression and anxiety over the pandemic. And it's also a very salient point that because so many of the kids are actually getting psychologic services with embedded psychologists and therapists within the school, a lot of these kids, when they have not been able to go to school, they're really losing their access to mental health needs in significant amounts. This group found that over 80% of children really were relying on school-based services to address mental health needs. And when the kids are not in school and they had not been in school for so long, a lot of these kids were really falling through the cracks, likely contributing to all of the mental health crisis we're seeing as a result of COVID-19. Did want to take, as I alluded to a few moments ago, a little bit of time to discuss some of the ethnic disparities and population disparities. The Latinx group are actually much more likely to develop depression and report higher rates of depression in comparison to Black non-Hispanic and white non-Hispanic youth. This is a group that is as at risk, and certainly they have a lot of experiences and adverse experiences that really make them more vulnerable to risk of developing depressive symptoms. And it's very important to not miss these kids either. Latinx adolescent girls do tend to report higher rates of depression and high prevalence of severe suicidal ideations and suicide attempts. And this is a bit of a shocking statistic, but Rodriguez and his group found that at least 1 in 3 Latinx adolescent females have seriously considered suicide. Again, a high-risk population and one that may not have really been adequately addressed historically. Further, we know that the description of adolescent depression, you have historically really been couched or described from data from white youth only. And this is also a bit of a problem because historically we've probably missed a lot of the kids who really do need help because they have not described it in the language of DSM-5 or earlier yet DSM-4, 4TR, DSM-3, 3TR, missing out on the descriptor, not understanding what the patient is really trying to tell you is also unfortunately a disparity that has probably lost some kids to care. Alfondu and his group found that mental illness may disproportionately impact Black youth compared to white counterparts. And we know that Black young people are frequently underrepresented in clinical care and research. So there is a gulf even in the research of trying to understand how to treat, who to treat, and really the best data. Alfondu and his group also suggested that there may be a lack of culturally sensitive treatments and provider bias in delivery of care that may lead to more unmet mental health needs for Blacks versus whites. And that, again, Black youth do report symptoms of depression and mood disorders in different ways that may really keep them slipping through the cracks and not adequately diagnosed or cared for. There's a suggestion that this lack of treatment may certainly result in an escalation of symptoms or the progression of depression into suicidal ideation or behavior. Obviously, that is a critical issue. The prevalence rates of depression stratified by race has really shown that there's a higher prevalence of depression for Black youth over white youth, 4.6 to 1.4%, and that some studies have really found that there is a limitations of reporting or reporting bias Some suggesting that there are concerns about the cultural validity of even the current depressive criteria as outlined in the DSM. I found this to be very interesting. Ofondu and his group, in admittedly a small sample of Black youth, in surveys, they found that even the language being used is really different. The descriptors being used are different, and these are things that clinicians should really be aware of. More like feelings of erratic emotional state, anger, irritability. Again, children and adolescents do tend to describe more anger and irritability rather than actual depression. But even in kind of the descriptor about just being irritable, feeling erratic, feeling bored, a loss of hope, loss of power, self-worth, self-affectation, feelings of confusion, helplessness, self-blame, feelings of being a non-human, being afraid or separated, being weak or having less energy or powerless, feeling rejected or invisible. Even this kind of loss of connectedness and trust to their peers and community, and this fear of losing oneself. These are descriptors that are somewhat different, and certainly, although you can kind of understand and see how there is the kernel of these types of things within the actual defined DSM criteria, the descriptors are different, and it's important to really understand what your patient is trying to describe. Now, I want to throw this in because, again, thinking about this from a primary care model, I wanted to take a few moments and start talking about a few other things that will impact depression. Obesity is a huge national trend. Even for a long time now in pediatrics, the obesity epidemic has been described since really the early aughts. We've known that this is a very significant problem in our country. And we have come to realize that obesity and depression are both common conditions among children and adolescents. In a survey of children and adolescents aged 2 to 19 from 2017 to 2018, they found, Fryer and his group found that the prevalence of obesity is 19.3%, affecting approximately 14.4 million children and adolescents in our country. Prevalence being 13.4% for 2 to 5-year-olds, 20.3 for 6 to 11-year-olds, 21.2 for 12 to 19-year-olds. Certainly finding the prevalence amongst Hispanic children and non-Hispanic Black children, white children, pretty well across the board, although rates are certainly different amongst some races and ethnicities. But these trends, which have been around for a while, have some very common causes and causations. Also, during COVID-19, we have found, not unsurprisingly, that the same problem has occurred with obesity. They have found, Lang and his group found that in a cohort of a rather large N of people, 432,000 between 2 and 19 in outpatient visits, the monthly rate of increase in BMI nearly doubled during COVID-19 compared to the pre-pandemic period. Certainly with an estimated proportion really increasing from 19.3 before pandemic to 22.4 within 2020, which were consistent with the Kaiser Permanente data, also suggesting the same problem with children and adolescents in Southern California. This is kind of what this looked like, that, as you can see, right at the start of the pandemic, across the board, with the exception of the 18 to 20-year-old subset, which did show some rise in body mass index. Otherwise, across the board, virtually all age ranges had gone up in some cases quite sharply, but certainly statistically significantly across the ages throughout the pandemic. Obesity also impacts, obviously, self-esteem. And interestingly enough, in one survey that Edwards and his group did, the misperception of overweight status amongst adolescents was found to be 23% for girls, 40% for boys. And that actually impacts the way that people may look at weight loss, or even the need for weight loss, weight control, and exercise. Obviously, if you misperceive what's going on, you're not going to address it. Risk factors for obesity have certainly been described. with a lot of social and socioeconomic risk factors. One group, Sugli and his group, found that 17% of children were obese by 5 years of age, and that 57% had at least one societal risk factor. The risk factors, and this is pretty key, and I would ask that you kind of bear these in mind, because you will see how a lot of overlap occurs with a lot of the other issues with depression. Risk factors that they found included partner violence, paternal depression, maternal substance abuse, food insecurity, housing insecurity, and paternal incarceration. Ogden and his group found significant differences in the prevalence of high BMI groups in US children at various age groups and ethnic groups at 3 BMI cut points. And the gist of it was basically that Hispanic boys tended to have higher BMI at all 3 cut points versus non-Hispanic whites. And although there were no statistically significant differences between non-Hispanic white and non-Hispanic Black individuals, there was a difference between non-Hispanic Black girls and non-Hispanic white girls at all cut points as well. Now, here's where it starts getting interesting. We know that obesity and depression have a lot of shared symptomatology, including sleep problems, sedentary behaviors, which, as an aside, have also significantly increased during COVID-19 pandemic, dysregulated food intake, and all of these things do tend to have a shared pathophysiological mechanism. A number of groups have actually found these same correlations with obesity correlating to depression and depressive symptomatology. Shaming experience in Sjorberg in his group, this was a study out of Sweden, showed that there was a very significant odds ratio of depression and depressive symptoms with obese youth that experience shaming experiences, bullying experiences, and the like. Goodman and Whitaker found that depressed moods significantly predicted obesity at a 1-year follow-up, even when controlling for other factors. Herva and his group found that obesity is associated with adult depression. Again, getting back to how all of these things are really interconnected. Anderson and his group found that anxiety was associated with a higher BMI in females. Early childhood depression also associated with higher BMI and weight gain as compared to non-depressed female. Now, how do these things potentially tie together? The HPA axis is one good way. Just to remind, that is the hypothalamic pituitary adrenal axis, kind of brain to kidney. We know that this is a central mammalian response to threat. It does help to manage the metabolic and cardiovascular response to acute and chronic stress. And the American Association has even identified that chronic stress and depression both lead to coronary artery disease and cardiovascular disease. We've recognized all of these things as being shared problems and kind of shared common pathways. The HPA axis also plays an important role in immune responses with pro-inflammatory cytokines that activate the HPA axis, cortisol being a very significant one, and probably most of us have heard of cortisol and the effect of cortisol. But we also know that the dysregulation of the HPA axis does have a lot of effects both on inflammatory process and immune process. Here's a really good graphics out of Pediatrics in showing kind of what ends up happening with stressors affecting cytokines in the hypothalamus, which then interact on the anterior pituitary, secreting ACTH, adrenocorticotrophin hormone, which then have a lot of effect on the cardiovascular system, musculoskeletal system, obviously the immune system, cytokines and cytokine formation, and how all of these things really affect when the stressor occurs. Even within this, we know that the neuroendocrine network has a lot of interaction as well, as this graphic also demonstrates that family functioning, trauma, caregiving, socioeconomic status, all of these things can buffer and affect how the immune system proliferates and balances, brain development itself, and of course the neuroendocrine stress responses with HPA reactivity, with hormones including glucocorticoids, And these can lead to a lot of chronic disease risk, infectious disease risk. Interestingly, it impacts cognition, learning, and memory because of how these things really affect sleep, as well as focus and concentration, obviously behavior and emotional regulation, and general overall psychological functioning. All of these parts really do interplay on each other. Now, the immune system also plays a significant role. We know that increased inflammation and altered stress system response are a common link between obesity and depression, and that obesity itself is considered a pro-inflammatory state. Both animal and human studies have demonstrated that adipose tissue express and secrete a number of pro-inflammatory cytokines, again, just kind of fueling this fire and all the connections between depression, chronic disease state, and the impact that all of these have on each other, sort of as a bilateral feedback loop. We know that obesity is a known independent risk factor for chronic disease state. Peripheral blood monocytes found to be altered in obesity with elevated systemic inflammation, increases the risk of chronic disease state, alters cytokines and chemokines that influence monocyte behavior, including seromonocyte chemoattractant protein 1, fractalin, interleukin 8, and everyone's favorite tumor necrosis factor alpha, which has a wide range of implications. But importantly, especially in children and some adults, cytokine interleukin 6 or IL-6 and tumor necrosis factor alpha have actually both been shown in numerous studies to have a lot of markers for depression. They have been found to be higher in adult psychiatric inpatients with major depressive disorder in comparison to normal controls. O'Brien and his group have found higher circulating rates of IL-6 in treatment refractory depression, again, as compared to normal controls, as well as euthymic individuals who were previously treatment refractory. There were even diurnal elevations in plasma IL-6 levels that really shift circadian rhythms in adults compared to other non-depressed adults, which will affect not only sleep, but also the regulation of the immune system, again, obesity and adipose tissue, and depression. Now, for kids, studies have also demonstrated that in overweight children, IL-6 tends to be much higher in comparison to normal weight controls. Again, potential link to further depressive disorders and depressive symptomatology. Schenker and his group actually found a direct association or correlation between circulating levels of IL-6 and depressive scores in kids that had undergone hematopoietic stem cell transplantation. Parvindu and his group found that in motor vehicle accident victims, there was a positive predictive diagnostic with morning IL-6 levels in pediatric patients who would then go on to develop PTSD. So again, the stress response from having a stressor occur shoots up levels of IL-6, and these actually put kids at risk from an acute stress response to the fulminant developing of PTSD. So we're seeing over the years that there have been multiple studies that have demonstrated how these things are really interconnected to at least potentially cause or come about to both PTSD and anxiety disorders, as well as perhaps a link to depression. Obesity also affects sleep. One study demonstrated that there is higher rates of insulin resistance with short-term partial sleep deprivation, and that sleep deprivation then increases hunger and insulin resistance, which only then again serves in a feedback loop to exacerbate or sustain obesity, again, causing more difficulties in that even in obese children, that insulin resistance that may already be there are also associated with shorter sleep duration by PSG. So again, all of these things just feeding back on one another. Sleep problems, we know, are a very prominent feature of adolescent depression, as demonstrated in the treatment of adolescent depression study, or the kind of seminal TADS study, that change in sleep was a very prevalent residual depressive symptom that can be very refractory. Sleep problems include both hypersomnia and insomnia, but also a dysomnia, just a difficulty staying asleep or just a dysregulated sleep. We know that adolescents with depression have prolonged sleep latency. Compared to non-depressed adolescents, and that is associated with a risk of depression recurrence amongst youth. Barb and his group found that in children aged 7 to 17, insomnia was correlated very positively with suicidality, as measured by suicidal thoughts and plans. We also know that overweight children obviously are at risk for sleep apnea, obesity, hypoventilation syndrome, all of which are associated with daytime somnolence and a total overall decreased sleep time. And actually just the other month, Bacharach, Danielson, Cohen, Levi found that obesity was independently associated with OSA in children, even after controlling for tonsillar adenoidal hypertrophy, and that for non-Hispanic Black race and Hispanic ethnicity were both independent risk factors for OSA that were not associated. So again, all of the sleep and sleep disorder will only serve not only as a part of depression, but then in a feedback loop perpetuates depression. So having bored you with all of that stuff, now getting to what do we do about this and what are some of the neurotransmitters involved? Serotonin, of course, is a monoamine that has been highly implicated in depressive disorders as well as anxiety disorders. And what presentation would be complete without some chemical model of one of the neurotransmitters of interest? Just to remind, serotonin is mainly produced, stored, and secreted in the neurons of the raphe nuclei, which are 8 of them along the midline of the brainstem, centered around the reticular formation, and that these axons really go into virtually every part of the central nervous system. There are certainly multiple serotonin receptors that have been identified on postsynaptic neurons, and we know, by the serotonin hypothesis, that the effects of serotonin and modulation of serotonin are targets of both our pharmaceutical armamentarium as well as some hallucinogenic drugs such as LSD and ecstasy. Just to kind of remind and give a nice graphic about this, the raphe nuclei there in the brainstem project all throughout the CNS. They have effects on mood, perception, memory, anger, aggression, fear, stress response, appetite, addiction, sexuality, but also other things like regulation, sleep, and circadian rhythms. Again, getting back to sleep and how that really is all affected, emesis, respiratory drive, etc. We know that serotonin has been linked to mood states, appetite, sleep regulation, again, how all these things tend to come together. We also know that carbohydrate intake does increase serotonin levels, which is why some people do describe that they will feel initially better for at least a little bit of time after eating like high carb foods, because it really does give that kind of release of serotonin, which can be very pleasurable until the guilt sets in. Gottlieb and his group found that there are high rates of cortisol secretions in girls subjected to stressors who are homozygous for the short arm promoter region of the serotonin transporter gene, a very important gene that probably a lot of us have heard about and is one of the targets of genomic assays. But then what is it really? Because certainly the folks from GeneSight and all kinds of other labs will talk about this as being one of their targets for so-called pharmacogenetics. But what it really is, it is on chromosome 17, it's at the Q12 location. And what is known about it is that there's a long allele, which is generally good, short allele, perhaps not as good. We know that it being homozygous, having 2 of the long arm forms may confer protection against anxiety and depression. Whereas having the 2 short arm genes of that promoter region may actually have a predilection towards anxiety and depression, with the general population being perhaps heterozygous for long arm, short arm, which then gives you the general population risk of major depression or a depressive episode. So having talked about all that, this is really the biggest issue and why treatment is so important, and that is about suicidality. Nationally, we know that The majority of children and adolescents who attempt suicide do have significant mental health disorders, typically depression. That suicide attempts are very impulsive and can come with sadness, confusion, anger, as well as problems with hyperactivity and attention. And just to kind of bear in mind, that level of impulsiveness is actually what makes children and adolescents so dangerous, because the time before thought and action for suicide can be on the order of seconds to minutes. And that impulsivity is one of the purported mechanisms for why suicide rates are so high in adolescence. Among teenagers, it is considered that suicide attempts are associated with stress, self-doubt, pressure to succeed, financial uncertainty, disappointment, loss, just kind of that easy solution. And it's certainly, as global stress goes up, there's a lot of uncertainty now, especially amongst Gen Z. Nationally, again, the point of this slide is that in subsequent studies, rates of suicide are just really going up and up and up, despite more efforts to raise awareness, more programs to raise awareness, more supports to try to prevent this. Nationally, rates of suicide are just climbing and climbing and climbing. A very sobering fact is that up to 50% of adolescents are successful. They will complete suicide on their first attempt. There are some seasonal trends, especially during the school year, because school can be very stressful for a majority of our children. Just to remind, suicide is the leading cause of death worldwide. 8.7% of males, 1.2% of females will die by suicide within 5 years of their first attempt, and that these increase within 15 years. Really, if you try it once, the greater likelihood is that you're going to try again until you potentially complete. So there is a very significant level of dangerousness with suicidal ideations. This graphic kind of demonstrates that from 2007 to 2015, the rates of suicide in adolescent males have increased quite significantly, from 10.8 per 100,000 to 14.1, which is a 31% increase. It had doubled actually for females in the same period of time, from 2.4 to a staggering 5.1 out of 100,000 people. And really, there's just so much suicidal ideations and suicide attempts presenting in our offices to ERs that it's just staggering. Even in North Carolina, might as well keep it here on the home base. It is the second leading cause of death from people aged 15 to 34, the third leading cause of death for children aged 10 to 14. In a survey from 2007 to 2016, 1,500 youth committed suicide, and it does account for 50% of the violent deaths recorded for the same population. Suicide being the third most likely cause of death, according to NIMH data, although there are some who propose that in the next survey, because of motor vehicle accidents usually taking the top spot, that number may even rise higher as people had not been out as much during the pandemic. A lot of risk factors for suicidal ideations and suicide attempt, including, of course, stress and loss, the bullying, which is very key and is certainly very, unfortunately, quite common in our schools. Childhood abuse, which some have suggested has also been on the rise during pandemic. Trauma, isolation, clearly, again, a byproduct of the pandemic. Disruption of violence, as well as gender and sexual orientation and social discrimination. One study actually suggested that even amongst the LGBTQ plus group, that having their family of origin or their caregivers support them and accept them can lower the rates of suicidal ideation by 81%. This really is a very key issue in the LGBTQ plus population. Child maltreatment, another big risk factor for suicidality, and it is one of the most pervasive risk factors for psychopathology and suicidal behavior. Certainly one study suggested that the population attributable risk is as high as 9.6% of males, 14.5% of females, and does appear to create or cause long-lasting neuronal changes that can be very difficult to reverse and tend to associate with emotional dysregulation, impulsivity, and really do appear to decrease the response to treatment and increase the likelihood of chronic and recurrent hospitalizations and recurrent symptomatology. One study suggested that child maltreatment in like my type of clinic, a child and adolescent psychiatric clinic, may be as high as 30 to 40% of what we see is because of child maltreatment. If you recall back to that previous slide about obesity, this should look very familiar. The so-called ACEs, the Adverse Childhood Experience Study, demonstrated that some of the biggest risk factors, again, same things with obesity, the poverty, parental substance abuse, parental mental illness, although this was not exactly just maternal depression, just parental mental illness, parental incarceration, domestic violence, all of these adverse experiences demonstrated dose-response relationship between the number of experiences and the likelihood of lifetime suicide attempts, which can be up to as high as 80%. These are, again, very kind of critical issues. So, having talked about all that, here's where it comes down to for primary care, and this is why it is so important for our primary care colleagues. Whitney and their group found in JAMA Pediatrics 2019 that 7.7 million children in the US have treatable mental health illness and have not received any mental health treatment. You can see that our own state, North Carolina, doesn't have the best statistics in the world. In fact, we're pretty high up there with prevalency rates in not receiving care. In fact, sadly, one of the highest rates of children who are struggling, who have prevalence of mental health disorders and are not receiving treatment. So how do we screen for this in primary care? PHQ-9 is a great place to start. Some people might not know that there's actually a PHQ-15. Really don't need to use that as much because the PHQ-9 really does the trick. Both of these measures have demonstrated good to excellent sensitivity and specificity for depression. The PHQ-15 also screens for somatization symptoms, but really the PHQ-9 does the trick with specificity and sensitivity of 88% for both. And it can be administered in less than 5 minutes without any apparent adjustment for at least some of the groups surveyed, Chinese American, Latino, Black subgroups, and seem to hold validity for English or translated versions. PHQ-15, which probably not a lot of people have really seen, it does screen for the somatic symptoms, but it actually loses a little bit in specificity and sensitivity, likely because of the addition of those somatic symptom questions. And interestingly, it does seem to be less sensitive in Latinx populations. For those who have not seen a PHQ-9, although I do think it's fairly universal at this point, it is the 9 questions with, obviously, again, the diminished interest or pleasure in doing things, the feeling down, problems with sleep, appetite, etc. The 9th question, of course, being sort of the major question, which is really the question about suicidality. Scoring, for those who may not have seen this, 0 to 4 is virtually nothing. 5 to 9, it suggests to be mild symptom where you can just watch and wait and repeat a follow-up. By a score of 10 to 14, really you should be considering what to do about this. 15 to 19, obviously fairly severe, where the recommendation is pharmacotherapy and or psychotherapy. 20 to 27 is severe, and really you should be doing something, if nothing more than getting somebody to a mental health professional. So, since we know that so many kids are not being treated, since it is hard to get into my clinic and other child and adolescent psychiatry clinics, primary care really is first line. And how does one manage it? Well, one manages it by psychoeducation and supportive management, family and school involvement, and there's a lot of good data to back that up. The therapies, it is true, there are cognitive behavioral therapy, dialectical behavioral therapy, interpersonal therapy. Not necessarily advocating that primary care really needs to be engaging in these therapies, but at least so that you've heard about them. And there's a lot of good empiric evidence, a lot of good evidence-based studies about the benefits of CBT, which is probably the one that most people are most familiar with. The SSRI antidepressants obviously play a significant role. Prozac and Lexapro, fluoxetine and escitalopram being primary amongst them, and are both FDA approved for the treatment of depression. It is recommended that treatment should last for at least 6 to 12 months to avoid a relapse. And really you're trying to get that remission to reduce or at least try to mitigate the likelihood of recurrence. You should also be trying to remind parents that there are groups out there for support, including NAMI, the Child Mind Institute, obviously the NIMH. In primary care, really should be providing a lot of education with risks, benefits, management of side effects, and always recommend getting both informed parental consent, but also, to really gain that therapeutic alliance, you want to try to get assent from the child, certainly from the adolescent. You really need that buy-in, and you need to have them really want to agree and accept the treatment as well. Now, of course, everyone's very worried about the black box warning, and the black box warning really is there for a reason. In meta-analysis of active antidepressants, it suggested that the risk of suicidal ideations was 4% for active antidepressant versus 2% for placebo. Within the meta-analysis, there was actually only one medication that made that number go up. And when the one medication, which happened to be Effexor XR, was taken out of that meta-analysis, the root is actually 2.4 to 2%. But nonetheless, because of the activation of antidepressants, it is very important to really try to mitigate that risk by very close follow-up and monitoring, so that if the child starts feeling a little bit better, but they're still having those suicidal thinking, the last thing you want to do is for them to have enough energy and enough motivation to act on it, which is kind of the purported theory about where that black box warning is really coming from. As I just mentioned, it is Effexor that has the highest rate of suicidal ideations within the treatment group, the meta-analysis treatment group. Back in 2003, Paxil was also dinged for this, and at this point, we really don't use Paxil in children. But Effexor XR did in fact have the highest rate in multiple meta-analyses. Generally, we do recommend that you start with an FDA-approved medication. Again, Prozac being FDA-approved down to the age of 7. Lexapro being FDA-approved down to the age of 12, which is where it's statistically separated out from placebo. And if you are going to go off-label, really would want to document why you're doing it and try to kind of back that up some when straying off-label. Now, even though there is that black box warning, studies have also demonstrated that suicide rates are inversely related to prescription rates of the SSRI, which basically means, insofar as saying that if you're not prescribing, you're having higher rates. And if you are prescribing, even though that black box warning does exist, really in suicide attempts because you're treating the patient. And again, in Brent's study, they demonstrated that suicide attempt or non-suicidal self-injurious behavior psychotherapy was also protected. So that combination of therapy and medication, always good. Now, I mentioned all about sleep because sleep is also a major problem. Insomnia is a potential and potent risk factor for suicide and suicidal ideations, and may be the first really presenting symptom to primary care. One study demonstrated that treating adults with CBT really lowered not only depressive symptoms, but also suicidal ideations, and is a very valid strategy for sleep routine, sleep hygiene, and CBT for sleep to try to treat this. And we know that insomnia really does have significant effects on focus and concentration, cognition, and memory, as well as the behavior at school. And so it's very important to really address sleep in children because you're trying to mitigate behavioral and academic consequences that come about from poor or dysregulated sleep. And again, to remind about previous slides, even in the TAD study, it was demonstrated that sleep was one of these lingering and lagging symptoms that were not really addressed even in the treatment of depression. And it really does have a profound impact academically, socially, even with suicidality. Now, that part of treatment actually pretty easy. So another part of primary care treatment of depression is the collaborative care model, which is really involving collaboration between mental health specialists and primary care settings to really improve care access and treatment outcomes, which has been demonstrated significantly in multiple different studies. In Brent's meta-analysis, 35 different studies of collaborative care models have really demonstrated significant improvements with emotional and behavioral disorders. Not quite as much on substance abuse disorder, which is kind of a whole other bailiwick into itself, but for behavioral and emotional disorders, that collaborative care model can really improve outcomes. One study demonstrated that in adolescent depression, there was a significant improvement of access and outcome and even cost effectiveness when you get that collaborative care model going. Primary care can also, especially like maybe more family practice, maybe med peds, but in treating the entire family, it can be very significant with the positive beneficial impact on treating the child. We know that parents who are depressed have youth that are depressed. They have suicidal youth, and really kind of getting the parent on board and in some cases, truly treating the family can be very pivotal. Multiple psychosocial interventions have been shown to prevent onset of depression in the offspring of depressed parents, even with a preventative impact, especially when maternal depression is apparent. And that treatment of maternal depression really does result in a reduction of externalizing, which is more that kind of aggressive behavior, and internalizing symptoms in children. So really addressing that depressed maternal caregiver can be very pivotal to prevent the onset of depression and some of the symptoms of depression in children. We know that the quality of the parent-child relationship, which literally begins at birth, can buffer against all the negative impacts of early adverse experiences, and positive parenting reduces the risk of externalizing as well as internalizing behavioral disorders and suicide attempts. Even that kind of low parental monitoring, letting kids do what they want, inconsistent discipline, so it's almost like a slot machine. Are they going to get disciplined or are they not? That variable reinforcement model just does not work, especially in adolescent alcohol and substance abuse and other conduct disorder externalizing symptomatology. Brent also demonstrated that family discord is a frequently reported risk for suicide attempts. So again, the chaos of the family, all of these kind of adverse experiences definitely impact, and treating the family as a whole, as a unit, can really significantly improve and modify the treatment and even sometimes prevent the onset of child and adolescent depressive disorders. One meta-analysis of 121 intervention studies found very significant overall effects with, again, the recurrence of parental training being one of the better things you can do to try to treat the family as a whole. And the positive parenting program model is a very well-studied parent training intervention that does reduce the rate of child maltreatment. Again, going back to those adverse experiences, which then lend to depressive illness in children. PCIT, perhaps not a lot of people have heard of PCIT in primary care, but that's parent-child interaction therapy. It really focuses on that kind of parental-child dyadic bond to reduce coercive behavior, really introduce effective discipline and positive parenting with a lot of positive feedback, which has been demonstrated to reduce maltreatment where abuse has already taken place. So PCIT can be a very effective management strategy, which even can be reinforced in the primary care setting during rechecks. One interesting program, Familias Unidas, has been designed to help first-generation Latino families where family conflict presents because of the difference in expectations between an immigrant parent and an acculturated teen. This program demonstrated, again, positive parenting, communication, monitoring, and it demonstrated that there was a significant reduction in the rate of suicide attempts, even 30 months after the program had concluded. A very potent treatment strategy for the family. The so-called family checkup has also been demonstrated that, again, in this intensive positive parent training, this was implemented on parents that already were having difficulties with parenting. In this one follow-up study, even 5 to 15 years after, it was really demonstrated that the study population had significantly reduced suicidal ideations or attempts when they got this family checkup strategy model with the parent training. And then finally, the community partners. We all need our community partners, and certainly, of course, now this is a little far-reaching, but if you can get community partnerships with schools and such to establish safe zones, especially with those discriminated populations, to identify gaps, specific populations, especially the LGBTQ population, really is to improve patient outcomes, with Kennard and his group finding that IOP programs reducing both depressive symptoms and depression disorders, as well as suicidal ideations in adolescent patients. So again, very effective when you can bring the community in as a whole. If you can support the community, you can really positively impact our children and adolescents who struggle with depression, with suicidality. Lastly, education. In primary care, we do a lot of educating, which include our teachers, our healthcare providers, who do have that kind of first line ability to identify children, to get them to help. Our ER staff, don't want to leave out the ER. Certainly trying to identify those people who are at risk of suicidality and of suicidal behaviors, and really to give that approach of knowledge, that calming presence, to really start trying to get to effective treatment, to offer help, which is the first step and offers people real hope that things can be better and things can be taken care of. I think that's pretty much about it.
Thank you, Dr. Trombley.